Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we kindly ask you to hold your questions till the end of the presentation. However, there's been a portion in which we're going to ask you for your comments on a specific question during the presentation. At that time, you can use the chat box and drop your questions there, and I'll read it out loud for the audience. Lastly, the CME credit will be displayed on the second slide and at the end of the presentation. Today's speaker is Dr. Fiester. Dr. Fiester is the Vice Chair for Education in the Department of Medical Ethics and Health Policy at the University of Pennsylvania Perelman School of Medicine. Dr. Fiester is the Faculty Program Director of the Master of Bioethics and Master of Sciences in Medical Ethics degrees. She is the Director of the Penn Program in Clinical Conflict Management, which promotes conflict resolution training for clinical providers and clinical ethics consultants. Dr. Fiester conducts workshops in conflict management throughout the United States and abroad. She serves in the role of academic conflict management consultant in the School of Arts and Sciences, working with academic units, strategic vision, improved communication, mediation, and organizational development. She has been a member of several international bioethics initiatives, including projects in Tanzania, the European Union, Singapore, and Japan. Dr. Fiester is the author of over 100 publications in the areas of clinical ethics, conflict management, LGBT bioethics, and medical ethics education. She recently was awarded by the University of Pennsylvania the Lindback Award for Distinguished Teaching. Please join us in welcoming Dr. Fiester in her presentation, The Difficult Patient Reconceived.
Thank you so much for having me. It is a gray day, but hopefully when you leave this session, you'll have some new ways of thinking about the difficult patient, and I'll also talk to you about some other resources if you'd like to think more about this very challenging question. Let me give you a second to do your CME sign-in here. Lots of numbers. This slide, as he said, will also be on the last slide in case you missed it, but let me just let everybody have a second to type all that in. So I've written quite a bit on the difficult patient. Some of the work that I'm drawing from today is from these papers. There are others, and I'd be very happy to share them with you. I'll give you my email address at the end so that you can contact me, and I can get them for you if you don't have access. Okay, let me talk about the objectives for this morning. First, I want to review the empirical literature on patients who have been deemed difficult. And I know that sometimes we don't like to use that word, so I often use the word challenging. When I use the word difficult, I'll put it in quotes. There is a pretty large literature, and I'll review that. But my goal is to reframe the way that clinicians think about challenging behavior from patients and families, because I believe that the way that difficult families and patients have been understood undermines your ability to have a fruitful path, a constructive path towards resolving those challenging interactions. So I'm going to offer a reconception and a different way of thinking about those problems. And in the journey to getting this reconception, I'm going to focus a little bit on anger and what the role of anger is in conflict. And I'm going to argue that anger should be understood the way philosophers understand anger, which is as a moral emotion. And understanding it that way will give you some avenues for de-escalating, rethinking, and then de-escalating tense interactions. So that's what's on the agenda. Let's think about just the argument as a whole. Let's start with how many clinicians think that how many patients do clinicians believe are challenging in the set of patients that they work with. The range is very large. Some studies show it as low as 15, and some show it as low as 60% are deemed difficult by their treating physician. The literature thinks about the problem as being sourced in the patient and family's pathology. So the literature often talks about the source of the problem being the patient. But mediators have a very different view. They think that behaviors that are labeled difficult or challenging are actually the product of responses to interactions and experiences that the patient or family thinks are not going well, that they perceive them as problematic or negative in terms of their experience or the delivery of medical care. So their perception of what's happening is driving these behaviors. And so mediators think that the source of the problem is the perception the patients and families have. And we'll talk a little bit more about perception in a minute. So that leads me to the argument that when you have a difficult patient, you have someone who's reacting to the perception of things not going well, either ill treatment, feeling morally wronged, or frustrated. And that new conception leads to a different path towards solution, namely employing skills to understand what those grievances are and to try to troubleshoot them, address them, and thereby reduce the challenge in the interaction. So before I go down the path of describing the literature, I want to acknowledge the profound problem that is caused by managing challenging patients and families for all of you. There is a very large literature that shows the profound consequences, negative consequences to you in having to manage these bouts of incivility and offensive language or disrespectful interactions. And those consequences can range all the way from psychological distress and frustration and anxiety, or even depression or dread of going to work, all the way to burnout, and then to folks leaving the field. So I want to start by saying that that trying to solve this problem for you is really important because the consequences to you are very serious. So now let's step back and look at what the early literature that examined the problem of the difficult patient, what did that literature show? It defined the problem exclusively from the clinician perspective. It asked clinicians, why are patients difficult, and what kind of difficulties are you having, and what's your view of why they are behaving this way? And the result of that literature was to say that to conclude that the cause of these behaviors was some type of psychological problem in the patient or family, or some type of character flaw in the patient or family, where the common hypothesis was that challenging patients and families had some type of moral failing or maybe even a psychiatric disorder. And the conclusion then was to lay at the feet of the patients and families, there is something wrong with you, and that's why you act this way. Now, even at the time that this literature was being amassed, and you know how in the empirical literature, there'll be a bandwagon, a wave of research that's done. So this is research that was done from probably 2001 to 2012. And, once a whole bunch of researchers have milked an area, then, people tend to turn their gaze. So most of the difficult patient studies and those kind of inquiries were done in that, let's say, 10-year time period. But even during that time period, intense research about the difficult patient, there was pushback about this analysis from physician researchers, even at the same time as the explanation for challenging patients was that there was something wrong with patients and families in terms of their moral or psychiatric health. There was a whole cadre of physician researchers looking at this problem with a different lens. And here are a few of them. For example, Gunderman and Gunderman argued that this explanation didn't perceive the patient in the right light. Elder Rice and Tobias said that there might be biases or other kind of attitudes that were happening that were leading individual clinicians to define patients in certain kinds of ways. Blackall and Green in the book Breaking the Cycle talked about potential blind spots. That this explanation that was being offered, it didn't really hit the mark. It wasn't a great explanatory model. Strauss, Ullman, and Kotler argued that what was really needed was a better understanding of the patient, because this literature, as I said, had come from the clinician perspective, not asking patients who were deemed difficult or challenging, what's happening with you? So my challenge in the work that I do is to think about the patient and family's perspective, not only so that they have a more satisfying experience, less traumatic experience of medical care, but also to think about solutions that might help the providers who are, really weighed down by these very negative interactions. And to think about this, I want to use a case. So let's think about the case of Fred. And this is where I'll ask for your participation in a minute. Fred is a 16-year-old with an incomplete C4 injury to his spinal cord as the result of a gunshot wound. He's currently unable to move his arms or legs, though he does have sensation in his lower extremities. Before his injury, Fred attended school intermittently and was on probation for heroin possession. His mother is unable to visit during the week because of her work schedule, and his elderly grandmother is homebound. Since he has come to the rehab hospital, Fred has been verbally abusive to staff, frequently using sexist or homophobic slurs. His cursing, often loud, distresses the other patients, as well as the physicians and other staff. Fred often complains of pain and screams loudly when moved, though his physicians insist he's on the highest dose of narcotics that they feel comfortable prescribing. Because of Fred's language and derogatory comments, both physicians and nurses are starting to refuse to work with him. Fred is clearly going to be deemed challenging because he is. But as a mediator, I want to ask the question, why is he acting this way? Not, is he acting badly? He absolutely is acting badly, and that's not controversial. He's clearly acting in a maladaptive and inappropriate way that is causing tremendous strain on the unit and the individual providers there. But why is he acting this way? Fred is angry. A lot of the interactions that you have with patients and families that are tense, that are not going well, that are not productive, have anger down at the base of it. So to think about anger and to try to understand why Fred is angry, I want to refer to a paper that I've nicknamed the 7 Maxims of Mediation. Not really its title, it was called What Mediators Can Teach Physicians About Managing Difficult Patients. But in this piece, I argued that there were 7 tenets of mediation that could help physicians. And the one I want to focus on for a moment here is Maxim 2, that anger is a reactive emotion. So the key to solving the problems that anger is generating is to understand the source of someone's anger. I want us to think about anger, and mediators think this way, as that anger is a symptom of a problem, and that often we focus in interpersonal reactions, interpersonal dynamics on the symptom and not the cause, which is odd because in other avenues, other arenas of our life, we don't focus so much on symptom as opposed to cause. If someone in your world is vomiting, you are not focused as much on the symptom as you are on why that person has that symptom. You're thinking about the cause. Well, mediators do the exact same thing. Anger is a response to something. We can't solve it by focusing on anger. And I really mean that we can't solve it in any way that mediators would call win-win by focusing on anger. So a lot of hospitals now will have signs that say incivility will not be tolerated, impolite and ugly behavior will not be tolerated. That is a perfect example of trying to solve the problem by focusing on a symptom rather than trying to understand the problem. And while techniques like that, like signs or behavior contracts, can work because they have a kind of threat to them, they're not win-win. They're win-lose. Somebody's going to lose because focusing on symptoms and not the causation doesn't actually solve the problem. It just drives it underground. So the first maxim that I want to think about for the purposes of the challenging patient, maxim 2, focusing on anger as a symptom. Okay, so let's think about the case from Fred's perspective. Why is Fred angry? What's making him angry? And when individuals first thinking about the dynamics that cause interpersonal conflict, think about a question like that, the non-mediator, they are likely to say in the case of Fred, Fred is angry at God, the shooter, and fate. And how could Fred not be angry at God, the shooter, and fate? Not everyone got shot. Not everyone's wound made them a quadriplegic. This is catastrophic for Fred. And how could he not feel that kind of rage at his circumstance? But the mediator says in response to those things that are true, that is true, Fred is certainly angry at God, the shooter, and fate. How could he not be? But in response to this as a hypothesis for why he's behaving this way here and what's making him angry, the mediator believes it's only part of the story. And because non-mediators have a very plausible hypothesis about why he's angry, God, the shooter, and fate, they often don't push themselves to any alternative hypotheses that would also be sources of Fred's anger. They believe that their explanation is the totalizing explanation for the entire set of his anger is explained by this. But mediators think that discourages us from reflecting on whether there's anything happening between us, anything happening here, anything in this unit, this rehab hospital with these interactions. And so while acknowledging the plausibility of that hypothesis, mediators want us to scratch the surface a little bit more and to try to understand whether there could be anything going on here that would be contributory, or maybe even a more serious cause, or not more serious, a more pressing and immediate cause than the hypothesis of the God, shooter, fate as sources. So a mediator is going to think that the way that he's behaving on the unit leads a mediator to believe that there's a strong probability he's not just angry at God, shooter, and fate, these externals, that he also is perceiving something here. And I'll say just as we move now to this next phase, Fred's perception may not be a mirror of reality. It may not be the case that there's any rational grounds for being angry at anyone at this unit. So his perceptions may not be accurate. But when you're trying to solve an interpersonal conflict, the truth value of his claim, something is happening on this unit, it misses the point. When you're a mediator, you have to think about the person's perceptions, not their reality. And by exploring their perceptions, maybe you can get to a different understanding, have Fred come to a different understanding about what's really happening on the unit. But we start with perceptions. And the hypothesis from a mediator looking at a situation like this is he's not just angry at externals. Okay, so this is where I want your brainstorming. I want you to think about one very narrow question. How do you think Fred thinks the staff think of him? Complex question. How would he describe how he's being treated? What would be his perception of the way that the staff view him? And the reason that I want to focus on this case, so think about the details that I was given when I was asked to help navigate this conflict. Think about what the author who wrote the write-up for this told me about Fred. And in light of the things that are known about him on the unit, what do you imagine is Fred's perception of the way that the staff view him? And now I would like you to type into the chat, and our moderator is going to read them. So let's get a whole bunch of answers. I think we've got one now, but let's go. Write as many as you can think of. How do you think that Fred believes he's perceived? How do you think they are? If you said, Fred, how does the staff view you? What do they think of you? Let's get a bunch more. We still only have a couple.
Yes. So Dr. Fiester, we have a few comments on the chat. We have Dr. Louise Green saying that Fred believes that he likely deserves his situation and his nasty attitude caused his current situation. We had a comment from
Okay, let me just
Susan
comment on
Walters.
that. As I'm going to slow you down because I want to amplify what people are saying and honor and elaborate on their contributions. So great. Yes, I think that Fred probably believes that there are eyes looking at him who say, you deserved this. You get what you get, so you shouldn't get upset. You put yourself in this situation. Okay, back to you for a second comment.
That he feels less than.
That he
Other comments.
less,
yes, less than, less than.
Okay, that they are judging him as being less than, let's say, the skier in the teenager who had a catastrophic ski accident in the next bed. That his roommate is viewed as he's viewed as less than that patient in his room. His
yes.
Yeah, good.
Two other comments is that he feels powerless and that they think he's annoying and hard to care for.
Okay, that they are thinking about him as being an annoyance, that they don't want to care for him. Okay, let's go up. I'm not getting enough yet about the first couple of lines. We in order to really brainstorm when you're managing challenging patients and families, you're going to do an iterative process where you're going to hypothesize, but then you're also going to talk to them about what's going on. And we can't talk to Fred because this is a case. But I want to make sure, I don't want to leave this. I'm gonna still put your feet to the fire here. I want to hear more about how do you think he believes he's being viewed given what the staff know about him. Because remember, the staff wrote this case. They know these things. They didn't make them up. They know certain things about him. If they know certain things about him, how might Fred think they view him in light of the facts that they know?
Before you made that comment, we had a few more that mentioned that either he was perceived as weak and worthless,
Okay.
or that he will feel that he will get more attention behaving this way.
He might. I mean, I don't want to deny attention seeking. There's more now. Let's think about
Yes.
what they know of him.
And then he will likely be ignored if it doesn't make them pay attention, and that they might think he's an opioid seeking behavior.
Okay, great. So let's hold there for a second. Right. That when he is when he is saying I'm in pain, he might be worried that they think he's drug seeking. Great. So imagine that you're in pain and you're being interpreted as being drug seeking. Great. What else? Excellent. They've all been great. I just want to get to a couple more insights and we'll move on.
Insecurity about his family limitations, and also insecurity about the inability of performing the things that a normal 16-year-old will do.
True. I mean, there's no doubt that it would make you angry that you are powerless and that you cannot do any of the things that a 16-year-old ought to be able to do. Your autonomy, your mobility, your sexuality. Of course, all of that is true. What about some of these other things that they know? How do they, what might his interpretation of them be in terms of where he was prior to this? Prior to getting shot, what might he think they're thinking about who he was prior to getting shot?
In that line, we had that he likely deserved what got to him, and that the staff might think that he's uneducated and does not understand anything.
Okay, uneducated, anything else? And we'll move on.
and that he was a troubled 16-year-old
Okay. So,
and a violent, yes,
please, yes, sorry.
and a violent person.
And a violent person, right? Okay, right. So from this description, he might think you are looking at me as if I am violent, drug seeking, heroin addict, dropout, junkie. That the fact that they know these things about him, he may be perceiving that they have a lens through which they're viewing him, and that lens it may be one of the sources of his anger. Okay, you did really well with this. So in light of that, and if we had Fred, we would talk to Fred. Right now we don't. But continuing on our brainstorming journey here, a mediator will say, what is Fred's experience on a daily basis? How often, for example, does he feel patronized, dismissed, demeaned, humiliated, stereotyped? If Fred feels any of those things, they aren't about the shooter or God or fate. They're about what he thinks is happening in this unit, which again, it may not be fair to the providers that these are his perceptions. But when you're trying to navigate challenging patient and family interactions, you have to put yourself in the perspective of the person in conflict to try to maybe get to a redefinition or reconception of what's happening. But first, you have to understand what they think. You mentioned powerless, and there's no doubt he feels that. And he certainly feels powerless and emasculated from this wound, from this horrible injury. But could it also be that he feels powerless and emasculated from the way that things are going on the unit? For example, one of the issues that the unit was very upset about was that he balked at his 7 a.m. physical therapy slot, but he didn't have any choice. They didn't give him a choice about when he had his physical therapy slot. And for a teenager, 7 a.m. is awfully early for physical therapy. Were there any senior citizens who might have been up since 5? That's a kind of powerlessness that doesn't come from being a quadriplegic. So is he, or for example, when they managed his bodily care, did they take pains to protect his pride and his dignity? Or did he feel that he was emasculated by the way that his body was being cared for, especially at that time of awkwardness with being, an adolescent and modesty? This is not laying any blame. It's just trying to understand what could be his perception such that we could all get on the same page. Does he feel heard? Does he feel validated? Does he feel respected? He very well may be respected, but does he feel respected? Does he feel as respected as the skiing accident in the bed next to him? Does he think that he's being treated as well as other patients? Or does he believe that they are prejudiced against him because of his truancy or his heroin use? Does he feel that he's being branded junkie, high school dropout, gang member? One of you, I think, helpfully said he might be thinking that people are seeing him as violent. That's absolutely the case. I gave this talk at a different university, and I talked about, and when I have more time, when I'm doing this as a workshop, I ask people to think about what the staff experiences. And inevitably, someone will say, I think the staff is afraid. What? And then I ask us to think that through. They're afraid of a quadriplegic. Afraid of what? We get this a lot. So the idea that he might be perceiving that people see him as violent, I think is not unrealistic. So, in summary, does he think that the care team really cares about him? And do they? Thing is, when someone has treated you the way Fred is treating everyone, we get to a point where we can't feel for them anymore. We get compassion fatigue. We get to the point where we put up the hand and say, I'm really done here. We're all like that. Human beings, it can only take maltreatment for a certain amount of time because it requires such an enormous amount of generosity. So have they gotten to the point where they don't care anymore? And does he see that? Well, the thing is, if Fred believes that he is being mistreated, misunderstood, or wronged, then he's not just concerned about the God, the shooter, or fate. He's having one of the immoral emotions provoked, the moral emotion of anger. So what is a moral emotion from a perspective of a mediator and in the field of philosophy? A moral emotion is a category of emotional response that functions as a radar for us human beings to detect threat. We flare up in the experience of one of the moral emotions when we have the perception, which doesn't mean it's true, but a perception that we are being offended, wronged, slighted, harmed, threatened. And there are classic emotions that are part of the moral emotion set: anger, resentment, and indignation. Resentment is this long-standing, low simmer of feeling wronged over some duration. Indignation is the how could you, how dare you do this to me? And that's sometimes felt for oneself or on the behalf of others. Altogether, moral emotions are a way of being equipped to safeguard our integrity, our physical integrity, our psychological integrity, our spiritual integrity. And so when we feel and perceive an incoming threat, anger is the emotion that flares up. So of course, when you think about God the shooter and fate, he is angry that why him? It shouldn't have been him. And so those hypotheses are very consistent with the theory of the moral emotions. But what I'm asking is there anything that he perceives going on in the unit that would also make him believe that he is being slighted, threatened, harmed, that he's the victim of wrongdoing? Persons who feel these moral emotions, indignation, resentment, and anger, are very susceptible to responding in counterproductive ways. And I want to groove here for a minute. When someone feels under siege, under threat, whether that is true or not, but it's their perception, they will frequently respond in maladaptive, inappropriate, and often counterproductive ways. Think about driving driving in the New Jersey Turnpike, 95, Garden State. And, it's like in New Jersey, people think you have to pay to put on a turn signal. You know what it's like on New Jersey highways. Somebody cuts you off and it was a close call. What do you feel? You feel rage. Many of us can get that emotion under some kind of control, and some of us can't. Some of us, start giving the finger out the window, screaming. My point here is that when you feel under siege, it is very easy for our behavior to go maladaptive, to go inappropriate, to violate the standards of decorum. So my claim is, often the challenging patient or family is reacting inappropriately, counterproductively to the perception that one or more of the things that matter to them are being dismissed, negated, thwarted, ignored, that they're being harmed. And this is a safeguard mechanism. If that's true, then Fred's concerns have to be addressed, even if his perception is false. If the difficult patient has a moral grievance, because that's the idea of the moral emotion, they pick up wrongdoing, and wrongdoing is about morality. And so moral emotions pick up moral grievance. They are our detector. So if I see someone's angry, my question is, how do you think, how do you believe, how do you perceive you've been aggrieved? And then try to address that grievance. So a mediator looks at Fred and says, what can be done to address Fred's concerns? And you might say, well, wait a minute. Which came first, his bad behavior or the perception that he's being treated badly. Now, imagine he came into this rehab hospital behaving badly. They didn't have time to treat him badly. He was behaving inappropriately from the minute he was transferred from the acute care hospital. It wasn't time to not treat him well. Let's assume that that's true, because it very well may be true. What reaction did he get at the rehab hospital to his understandable feelings of anger and frustration? Not just at God, the shooter, and fate, but maybe things hadn't gone well for him. Maybe he believes that he was not treated well at the acute care hospital. We are not great compartmentalizers. If we have been angry at this set of clinicians, we bring that with us. If we have been angry at this set of nurses, we bring it with us. Let's think for a second about of trauma-informed care, something that all of you have heard about, and really important development in thinking about medical care and the experience of being a patient and or a family member. What the TIC investigators know and can show is that medical trauma from one experience is carried forward into future medical care. It isn't left at the door and you start the second experience fresh with a clean slate. Trauma is carried over. So what response did he get from the rehab hospital if he was carrying feelings of being affronted or harmed from the other hospital? What stereotypes and bias might have undergirded some of the ways that people were interacting with him? The eye contact, the number of sentences said, the tone. Was there any bias? They knew a lot about his past that was not clinically relevant. So, whether he was a high school dropout was not germane to any part of his clinical care, but they knew it. And so did that color the way that they saw him, so that they added fuel to the anger fire? What sources of support did they offer him? Did they assure him, you're going to be okay here. You're going to be safe here. Your emotional well-being, your physical well-being, your spiritual well-being, you're going to be safe here. How did they address his grievances? Did they employ trauma-informed care principles? But wait, you might say, sometimes patients really do have a psychiatric illness. Fred may have a personality disorder or a psychiatric diagnosis. So my hypothesis so far has been Fred is a normal, a neurotypical person, a mental health, very typical, no serious psychiatric diagnosis. But what if he actually has a serious psychiatric diagnosis, Autumn, and you're ignoring it? This approach that I'm advocating is advocated by not only by psychiatry, but a lot of the best literature on managing challenging patients and families is coming out of the discipline of psychiatry. I'm not in tension or conflict with what's coming out of psychiatry. I utilize the work coming out of psychiatry, and they are managing individuals with significant mental health conditions and still are arguing that this is the way that you go about trying to diffuse and de-escalate interpersonal conflict at the unit. And that leads me to the argument that we actually have an ethical obligation to the difficult patient, not to put signs up that say, don't be difficult, but to mine those interactions and try to understand them. Because if they perceive themselves as being wronged, and sometimes it's not that I'm wronged by a person. I might be wronged by the system. I can give lots of examples where that I've been, in cases I've been involved with, where a nurse or a physician enters the room and the person already feels violated by the system. Appointments that were not properly scheduled and all kinds of mishaps. And there are so many ways that people can feel that the system has violated them with no face to talk to about that kind of harm. And again, we're not compartmentalizers. So if patients perceive themselves as having been wronged by the medical encounter, well, then there's an ethical obligation to address, to validate, to repair, to assist, to try to work with those patients and families to try to understand. And this is not at all to make physicians into therapists because it's not what you do, unless you're a psychiatrist. But for those of you in medicine, that's not what you do. But what you can do is get the right resources, bring the right resources to bear. It may not be you, but it may be that you know how to get the specialists or the resources to help. You do that all the time. You are frequently getting an infectious disease consult, an oncology consult, nephrology consult. It's the same kind of approach. Something is going wrong here. You identify what it is in this interaction, and then you find who is that person who can address and repair, assist, but you can certainly validate. And the duty to work with those patients and families to try to get to the causation and not to fixate on the symptom, that exists, that duty, whether the harm is perceived or real. So where have we gotten to in these few minutes? The prevalent view of the challenging patient and family is that patient pathology is at the source of it. If it is, many people will say, if it's a pathology, there's nothing I can do about it. Mediators don't see it that way. Apparently, psychiatrists don't see it that way either. That challenging behaviors are a maladaptive response to what? To the perception of a grievance, to a perceived affront. So what we need to do is find the source of that so we can really solve it, not band-aid it, not drive it underground, not coerce, but solve. If a difficult patient feels morally wronged, then we have to understand what's going on there and bring the right personnel to bear to solve it, not focusing on cause. Sorry, focusing on cause, not focusing on effect. And we do too much focusing on effect for understandable reasons. But it sabotages our ability to really solve it. All right, I'm going to put that up while we gather your objections and questions and comments.
Dr. Fiester, thank you for that really insightful talk and presentation, and the profound importance of heightening our awareness around these issues that I think all of us deal with and struggle with. So really appreciate the idea of moral, the concept of really moral anger, and then the ethical obligation for us to try our best to deal with it. And so I want to encourage, we have a few minutes, which is great. I want to encourage everybody to either speak up or raise your hand or put it in the chat box. And while we're waiting for that, let me ask a question. I think we certainly see, I'm sure you do as well, when language is a barrier, and there are moral, there could be a grievance perceived around that as well. How do you deal with that particular challenge? Patients, if one is a native English speaker, the patient a native Spanish speaker, and then the family dynamics around that also. I have a particular patient of my own in mind where I think that's operational. But do you do anything different?
I think you're absolutely right.
Yeah.
You're raising such an important problem. And by the way, I'll just say that I put my email in the chat list. I've done some podcasts. I have lots of articles. So if anyone wants more on this, just write to me. And so it's in there. In a country that has this kind of linguistic diversity, this many languages spoken, this many folks who are visiting or who are immigrants who don't speak English as their first language, this magnifies the problem exponentially, because even native English speakers to native English speakers misunderstand each other all the time. It is so challenging for us to understand each other. And I've done a lot of work about how little we understand when other people talk, even when we're in the same language. Now add a language barrier. And and even navigating the solution to conflict requires such linguistic subtlety, so that even when you're trying to communicate with someone who's not speaking your language, all the subtlety in the way that you would speak to that you're trying to convey is going to be lost. So it's going to be very hard to convey the kind of empathy and inquiry. And I also think in some moments we have the right kind of translators accessible, but translators are not always there. So I think you raised a problem that I'll give you some thoughts about what to do. But the first, obviously, is can you find the resource to get that translator in, even if it's not in that moment, but to bring somebody in so that you're at least speaking with somebody who can go back and forth between the two languages. That may not be possible. It's often not possible, right? We have moments where translators are available and a lot of interactions where they're just not, and they're not on speed dial. And I mean, do you have them in all of the various languages that are spoken? So I'm not minimizing the problem. Then rely on body language. Think about how much you can convey with forward leaning, open gesture, eye contact, sympathetic expressions to at least connote, to at least emote that and gesture or try to signal empathy or compassion or concern, to at least in those early moments when you're trying to get that thing de-escalated, if you let your body say, I want to help, I'm not sure how, I'm here, those kind of things too, you can get that ultimate Band-Aid. That's the Band-Aid, so you can ultimately get a solution, because you're right. Doing mediation through language barrier is incredibly hard. Also, one of the things that you can do is to think about simplifying your language so that if you think about learning a foreign language in stages, I always say I'm about a sixth grader in German. So if you were operating anything beyond sixth grade, I don't know what you're saying. So maybe simplifying, but it's not a small problem. I agree.
Yeah, no, but thanks for those comments. I mean, yeah, it's, we have interpretive services are on the phone, so they're not there in the moment, and some of these nuances are always a challenge. But thank you for that. There are other things that we can do. Appreciate that. Other comments or questions?
So I see one here.
Sorry.
You, I'm sorry.
No, go. Let's see. Oh, yeah, there is somebody, Dr. Presso. How do you envision a possible positive resolution for Fred and the rehab providers?
So I think about conflict management as having two levels of skills. One we'll call learn to work a fire extinguisher. Another we'll call learn to be a firefighter. And the kind of workshops I do, and I've got something that is in the MedEd portal so that's a resource everyone can use. I've got some podcasts. They are, and obviously I come and I do workshops as well. They are fire extinguisher training. How do you get the fire extinguisher open? How to use it for a small kitchen fire? And then there's the more 4-day kind of intensive 4 to 8 day immersion where you're learning how to be a firefighter. You are right to point out that Fred is going to need a firefighter to solve it at this point. So a lot of my work is to get fire extinguishers into as many hands of nurses and physicians, social workers, clergy as I can, so that we never get to the room being ablazed, because there's just not that many people out there in the unit, in the institution, that have those firefighter skills. I'm starting a project working, as I see somebody's got a comment from patient and guest services, making sure that all of those individuals have fire extinguishers, because not every office of patient and guest services have people trained in conflict management. Yours may, but then having point people in that unit that would actually have firefighter skills. And so Fred it requires a firefighter. That's going to be somebody who's got 4 to 8 days of mediation training, that's going to pick apart, is going to have substantial time to invest in unpacking what's going wrong, brainstorming solutions, working to try to find a way back for the providers, start to find a nurse or a physician that is willing to start over, to try it again. That's going to be a firefighter. What could have been done at the beginning? That list of questions that I gave. Let's see, can I get them? Can I get them back? Let me see if I can. I may not be able to, but that list of, I can. Here, let me give you this set. There you go. When somebody first comes in, you can smell smoke. All of us, you're not trained in mediation, most of you, but you can still smell smoke. You smell smoke, you start working on these questions. You start thinking about, okay, I smell smoke. We need to do something. Get your fire extinguisher out. And if it isn't you, who's the right person to try to sniff out what's going on with that smoke early on? Because you're absolutely right. A lot of times, the intervention of the firefighter isn't brought in until that thing is so far ablaze. We may not be able to salvage that situation with Fred. It's so far gone. The mediators are optimists, and if you brought someone in like me, I would believe I'm just going to try. I'm just going to work it till everyone refuses to work with me. But let's try to get fire extinguishers in everyone's hands so it doesn't come to that, because it isn't going to be simple to get this. The faith in with Fred's faith has been shot, and your faith in
Thank you.
Fred's sorry.
Thank you. Yeah, thank you so much. I think I see Dr. Weinberger. You have your hand up.
Yes, thank you. Thanks for the talk. I have two statements or questions which may be controversial. One is that sometimes the isn't a difficult patient, it's a difficult doctor. We've all encountered doctors who don't deal well with patients individually and can inspire a borderline patient to become difficult. And the other is that in my practice, whether as a private practice rheumatologist or when I was employed as a rheumatologist, I was luckily enough time to deal with a lot of these patients' problems more than other people would, because I was given the time or allowed the time to do it. And if you have a 10-minute visit with a quote difficult patient, it's not going to be easy.
No, those are great comments. Really great. Now, the first one isn't controversial to me, but probably to your audience. Let's talk about that for a second, and then we'll get to the time crunch, because you're absolutely right. Let's talk about individuals who I met a surgeon once who said of himself, I have the empathy of a leaf, of a flower. I got no empathy. That was a self-description, which I thought was a remarkable self-knowledge there. But what I say is there for individuals who sort of provoke conflict, they can be given skills, not maybe because they buy into the mission of the patient experience and the Press Ganey and the let's not have trauma in medical care, simply because these skills will make your life better. And so when you find someone who seems pretty low on the empathy scale, not so good on the bedside manner, says things that ruffle feathers, there are things that we can teach, not because you should be a better person or a better doctor, forget that, because you want to have a better life. You want to have a smoother clinical experience in your profession. You don't want to be knocking your head against the wall all the time. So we have techniques that we can teach that can say, okay, if you do this, then that's going to provoke that. And you don't want that, so let's not do that. Instead, let's think of it like this. So my first response is to say, we don't need to change moral character. We don't need to have people drink Kool-Aid. We just have to convey that your life is so much better as a clinician or nurse when things go smoothly than when they don't. So let's see what we can do to make things go better. Strategic, a calculus can help them say, look, it's in my self-interest. Even if I don't buy into that whole doc, patience and sympathy, I can still buy into self-interest. It's in my interest to learn some techniques that don't chafe at people, because it'll make my life better. So that's one thing we can do to help people who are not really that interested, but boy, everyone wants to have less conflict in their life. Second thing is about time, and you're absolutely right. We have to be careful about how we triage this. A clinician has 30 seconds. No matter, unless, in only the craziest circumstances, everybody's got 30 seconds to a minute. If we can get fire extinguishers into enough hands, you can get things calmed down pretty fast in 30 to 60 seconds. You're not in for the big slog. Fred, you're talking about hours. Percolating conflict, when you smell smoke, you can get that troubleshooted pretty quickly. I mean, think about how many conflicts you avert in your life. You are racing around the grocery store because you didn't have enough time. You go around the corner, you slam into somebody. Oops, you've now run over somebody's foot, and you say, oh my gosh, I am so sorry. I was careless. How are you? Are you okay? It takes so few seconds to get that thing to calm down. And when you do that, when you respond like that, the other person is going to say, it's okay, I understand. Or in the case of a clinical interaction, I'm so sorry this didn't go well. It's all right, I know it's not your fault. What can I do? Let's hear it. And then you triage to somebody else. So I think that what clinicians and nurses, especially clinicians, what they need is the plan. What's going to be the plan when this happens? Who are your resources? What's your escalating? Working with your patient and guest relations office or your ethics service. How do you get, or maybe you just have people that are the point people for conflict management, your clergy, your social workers, maybe someone from nursing, that's your plan to get somebody triaged. Because you don't have time to get involved in a big slog. You can try not to create conflict, and you can try things that are quick de-escalations, and then you need to get resources.
Thanks so much. That's a really great and practical, I think, which really is very applicable in many situations. Thanks so much. Dr. Deaver?
Yes, thank you so much, and thanks for giving us some more tools. So we're very fortunate here at Rutgers and University Hospital. We get a lot of training on trauma-informed care. We have strong family support team. We have great patient, relations, guest relations. And still, what I'm asking you is, what do you do in the moment? And, I'm going to, look at this, your presentation again, think about this when I go into a room. But for those of us that are not really trained in mediation, it is, what do we have a lot of FREDs at our, in our hospital. And I think we managed, these challenging patients well. But we do have this one in your moment, and then somebody's throwing, containers off their tray, at the staff, literally trying to hit them, with it. In the moment, we still need, like what you talked about, is kind of de-escalation, ability. Because you just can't run out of the room.
No, certainly not. Okay, so let me put this in. So if you put into the browser MedEd portal, which is the AAMC's repository for training stuff, and my name, you'll get a look, sort of a mini workshop. I also do workshops that give people these techniques. So we have 2 minutes. I'll give you the quickest synopsis here. I'll give you 3 quick things, but they all need like an hour training to learn. So what do? First of all, you think about trying to put yourself in the position of the other person. Think about getting the view from that person. 2, identify what is most central to that person. What are their interests? Not the positions they take. What's the source of it? What matters to them? And try to get yourself focused on what matters to them in this moment. And then laser lock on the content of what they're saying and paraphrase it back to them. Not parrot, paraphrase. So if they're yelling, look for what the content is. Sometimes clinicians think that this is venting, and so it's just smoke without content. There's no smoke without fire. Find the fire. What is it that they're saying? They're not going blah, 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 blah. They're not making gibberish. They're actually saying something. So immediately laser lock on the guts of what they're saying and say it back to them. To say, because what you're doing when you repeat back to someone is you're saying, you're not using the phrase, I've heard you, which everybody thinks is BS. You've heard me. I don't know that you've heard me. That's show. That's tell, not show. Repeat back to them the actual content of what they're saying. Because when people are escalating up, what they're really doing is saying, you're not hearing me, you're not hearing me, you're really not hearing me, you're not hearing me. So you need to not say, I hear you, I hear you, I hear you. You need to demonstrate that you hear. What I'm hearing your concern is you're expressing this to me. Your perception is this is what's happening. You see this is, you're naming this. That's what you're giving back to them. That's my quick and dirty. We need an hour-and-a-half session you can bring me back for, and I'll train you to do this. But that's the thing in the moment.
Thank you.
You're welcome.
Dr. Fiester, I think that maybe that's not a bad idea. And thanks for
You're welcome.
making us aware of the MedEd portal also, and also the fact that you go and you do training. That's, I think, really important, something that we can think about maybe having and doing over here with you. So appreciate that very much. Time is up for today. I want to thank you for this really tremendously insightful and morally awakening presentation. And I want to thank everybody for joining this morning, and wish everybody a great rest of the day. Thanks so much again.
And don't hesitate to reach out to me. You got my email. I've got podcasts and other things as well. So thank you for having me. What a great audience you've been.
Thank you. Be well.
Take care.